Hello students, welcome to this INICET May 2024 recall session. So in this session what we'll do is we'll try and recall as many INICET otorhinolaryngology, that is ENT questions that have come in the recent May edition. So hope all of you have done well in your exams, and I hope the results are going to be in your favor. So cutting everything short, let's go directly to the recalls. Let me just stream. Right, so let's begin with the recall session. So what was the first question? Let's discuss. I think there were around 9 questions in ENT that have come in INICET. So what we're going to do is go through them one by one. So let's start with the first question. One of the questions that is an overlap, I have put this in ENT as well. I think it may be well discussed in surgery as well. So this was one of the steps, since it is an overlap between ENT and head and neck surgery and ENT. I've discussed this here as well. Which of the following steps in thyroidectomy will not result in hoarseness of voice? So these were the 4 options that were given. That is ligation of the superior thyroid artery, division of the strap muscles, dissection of the tubercle of Zucker candle, and dissection of Baer's triangle. So let's dissect all these options one by one. First, you have ligation of the superior thyroid artery. So if we consider the superior thyroid artery as an option, that is the superior pedicle or the superior pole of the thyroid gland. So one of the important triangles that is in relation to the superior pole is known as the Jol's triangle, right? So when we talk about Jol's triangle, it has got 3 important boundaries. So when we talk about the boundaries of Jol's triangle, the first important boundary is the midline. Second important boundary is the attachment of strap muscles. And the third important boundary is the superior pedicle itself, or the superior part of the thyroid gland along with the vessel. So this triangle is also known as the sternothyrolaryngeal triangle. So when we talk about the triangle, let me draw the boundaries again. You have the attachment of the straps above, you have the midline, and then you have the thyroid pedicle, that is the superior pole of the thyroid gland going up like that along with the superior pedicle. So what is the importance of this triangle is the superior laryngeal nerve is very closely related or lies within the triangle. So this is one important aspect. If you look at the second important aspect with relation to this triangle, you have to know about the external branch of the superior laryngeal nerve. We have a classification which is called as Cernia classification. This is the relation of the external branch of superior laryngeal nerve in association with the superior thyroid artery. So there are 3 important grades here. If I were to say what is grade, it is divided into grade 1, grade 2A and grade 2B, or type 1, type 2A and type 2B. What is type 1? The external branch of superior laryngeal nerve crosses the superior thyroid artery more than 1 centimeter above. So you have the external branch of superior laryngeal nerve, the superior thyroid artery, it crosses more than 1 centimeter above. What is 2A? It is less than 1 centimeter. So the crossing of the superior thyroid artery and the external branch of the superior laryngeal nerve is less than 1 centimeter. And when we talk about 2B, The external branch of the superior laryngeal nerve may well lie within the pedicle or within the superior pole of the thyroid gland. So, ligation of the superior thyroid artery does not become an option, basically because of the fact of these classifications, right? So, it can injure the superior laryngeal nerve or the external branch of superior laryngeal nerve, and hence it can produce hoarseness of voice. So this option is out for this question. Let's look at dissection of tubercle of Zucker-Kandel. Tubercle of Zucker-Kandel is located in the posterior part of the thyroid gland. It is very closely related to the cricothyroid joint. And at the same time, what you need to remember about the tubercle of Zucker-Kandel is it's very closely related to the recurrent laryngeal nerve and the superior parathyroid. So when you're dissecting the tubercle of Zucker-Kandel, there is a chance that you can injure the recurrent laryngeal nerve. So this option is also out. The third option here is dissection of the Bear's triangle. So when we talk about the Bear's triangle, it is one of the important landmarks for the recurrent laryngeal nerve. So when you talk about the Bear's triangle, the three landmarks that are present here, one is the common carotid artery. Then you have the inferior thyroid artery which goes to the thyroid gland. And the third boundary is formed by the recurrent laryngeal nerve. So if you fail to identify any one of them, then there can be injury to the recurrent laryngeal nerve. So this option also goes away. So division of strap muscles may produce a certain variation, but it will not produce a hoarseness of voice. So this would be the right answer to you, right? So that is about the first multiple choice question. Now let's come to the second multiple choice question. If anyone has any doubts, you can definitely put it in the chat box. I would be more than happy to answer any one of them. Right? So now let's come to the second multiple choice question. You have a 32-year-old man who presents with sudden lower motor neuron facial paralysis with no other clinical causes. Which of the following is the treatment of choice? Mark this keyword here, that is treatment of choice, right? So what we are looking at here, without a clinical cause, you have a lower motor neuron type of facial paralysis. You are looking at Bell's palsy. So when we talk about Bell's palsy, what is the treatment of choice? This is a straightforward answer. The answer is oral steroids. You should give 1 milligram per kg of prednisolone over 14 days. That is the criteria or the treatment of choice in cases of Bell's palsy, which you can taper later after 14 days. Right? So 1 milligram per kg of prednisolone is the treatment of choice for Bell's palsy. Now, what is the cause for Bell's palsy? There are multiple causes, right? So when we talk about Bell's palsy, you have the keywords here. You have acute lower motor neuron type of facial paralysis. We have the most important causes, that is viral and vascular. So there is reduction in the blood supply to the facial nerve which can produce Bell's palsy. There can be an inflammation which is caused by a virus. When we talk about virus, the most common viruses that are affected in Bell's palsy are the herpes simplex virus and the herpes zoster or the varicella zoster virus. Now, when there is an infection, there is inflammation of the facial nerve in the labyrinthine segment or any other segment, most common being the labyrinthine segment. This is responsible for causing Bell's palsy, right? Now, the third important feature here is a Bell's phenomenon. Bell's phenomenon is when the patient tries to close the eyes, the eye rolls upwards. That is Bell's phenomenon. The fourth important feature you can have in a Bell's palsy is ear pain. This has been implicated. There are a few papers which says that ear pain is due to seventh nerve causing referred otalgia due to Bell's palsy. So Bell's palsy can cause referred otalgia via the seventh nerve is what is mentioned in literature. Although Textbooks do not mention it. It is mentioned in a few articles that are published in literature. Good evening, Wondergap. Then the other features of Bell's palsy are loss of taste and noise intolerance. So when you talk about Bell's palsy, you have viral, you have vascular, although what we are trying to do as far as treatment aspect is concerned is we are going to reduce the edema around the nerve first, right? So the investigations more or less are complementary to it. It is more often a clinical diagnosis, and there are wide range of treatment modalities that are mentioned in this slide. If you look at this, steroids are always the first choice. Analgesics plus minus to relieve the ear pain. More often it is neuropathic type of pain. You will have to give them neuroleptic management. Physiotherapy has been used and it has been found to be beneficial in literature. Antivirals. More often than not, when we talk about Bell's palsy, steroids are started along with antivirals. But if you look at the options here, it is not mentioned at all. So if you talk about one single or the best treatment of choice in this condition, you have oral steroids. If option of oral steroids along with acyclovir was given, that would be the treatment of choice and not oral steroids alone. Antibiotics is always ruled out, not necessary at all in case of Bell's palsy. What about facial nerve decompression? If you look at literature, once again, it says that you do a electroneuronography and electromyography if this is suggestive of facial nerve degeneration. If there is worsening facial nerve degeneration, ENOG is usually up to 21 days, there is worsening facial nerve degeneration, you can always go ahead and do a surgical therapy in the form of facial nerve decompression. But the treatment of choice always in cases of Bell's palsy, first line of management is steroids along with antivirals. If there's a mismatch of options, steroids is the single best choice. Good evening, Dr. Vinay. Now let's come to the third multiple choice question. Straightforward. This has been covered again and again in the chapter on epistaxis. It has been covered in the chapter on in nasopharyngeal tumors in the Manipal MedAce app. All of you can go and check out the app. There are lots and lots of features. We've been able to get 8 out of 9 questions from ENT from the app and the reels that we have been doing over a period of last 2-3 months. Now this question, straightforward, 13-year-old boy presented to the outpatient department with right-sided nasal obstruction. See here, unilateral nasal obstruction. Profuse recurrent epistaxis, 6 months duration. So what I've done is I've marked out all the keywords. You have the 13-year-old boy, right-sided, that is unilateral nasal obstruction. You have profuse recurrent epistaxis, which stops by itself over 6 months duration. So this child would have lost a lot of blood over a period of few months. Now what were the options given? Allergic rhinitis, definitely ruled out, does not cause epistaxis. Antrochoanal polyp, ruled out. Occasionally an infected polyp may produce a minimal bleed, but profuse recurrent epistaxis is definitely not there in antrochoanal polyp. The two important choices which can cause profuse epistaxis have been left behind here, right? You have coagulation disorder and JNA. So how will you choose the answer? Answer is straightforward here because of the fact that it is unilateral nasal obstruction. When you have a coagulation disorder, it is going to be bilateral epistaxis and bleeding. So it can be recurrent bleeding, but this is 6 months duration, right? So always the choice in this case will be a JNA. So when we talk about JNA, these are all the features. They may give you an image based question. JNA is one of the important questions that has been asked again and again in any of the entrances. Once again, it has been repeated in INICET. So when you look at this, would be the clinical picture. You have very fragile vessels lying on the surface of the tumor here, and when you try to probe, never try to probe a JNA. When you try to probe a JNA, it's going to bleed. So it's a very fragile tumor. It's got a vascular component and a fibrous component. So always make it a point to see the image, and if it is given, definitely, if it's not given, you'll have a clinical picture like that. So treat the options or the Key points that you need to look for in the multiple choice question would be nasal obstruction. In this case it would be a unilateral nasal obstruction. If the tumor grows, definitely it can be a bilateral nasal obstruction. It can produce eustachian tube obstruction and come present to you with a otitis media with effusion. One of the important points that you need to remember as far as JNA is concerned is epistaxis and other important points. Based on the spread, it can have orbital symptoms, you can have infratemporal fossa symptoms, it can spread to the nasopharynx, and it can have an intracranial spread, right? So when you talk about the management of juvenile nasopharyngeal angiofibroma, always you would like to image. When you talk about imaging, you look at a contrast enhanced CT scan and an MRI. Both are required. You need to look at the bone, you need to look at the soft tissue extension. One of the important points that I forgot to tell you in the beginning is the origin. The origin of juvenile nasopharyngeal angiofibroma is at the pterygoid wedge. Remember that it is at the pterygoid wedge around the spinopalatine foramen. Treatment, most often the treatment of choice is surgery. You would like to embolize the tumor beforehand and then go ahead and operate on the patient. Now let's look at the next question. Straightforward answer here. Okay, once again this is a straightforward MCQ that has been asked in INICET. Which of the following interventions is not done in an 8-year-old boy with bilateral sensory neural hearing loss? If you look at the options, hearing aids definitely indicated in sensory neural hearing loss. Cochlear implants definitely indicated in sensory neural hearing loss. If the child is not able to hear in the classroom, obviously the teacher would want the child to sit in front. That is what has been mentioned here, preferential first row seating in the classroom. And the last option here is adenoidectomy with grommet. Remember, adenoid enlargement causes a conductive hearing loss and most often a bilateral conductive hearing loss, right? When the adenoid enlarges in the nasopharynx, it causes bilateral eustachian tube obstruction. When there is bilateral eustachian tube obstruction, there is bilateral otitis media with effusion. So the treatment of choice in adenoid would be an adenoidectomy along with myringotomy and grommet insertion. Now, what I have put in this slide is the treatment of hearing loss. Good evening, Dr. Anjana. So what is the treatment of hearing loss? This is in general that I have put forth. In bilateral sensory neural hearing loss, you can go for hearing aids, you can go for middle ear implant, you can go for cochlear implant, and in case the cochlear nerve is absent, you can always go for a brainstem implant. When you talk about conductive hearing loss, you always need to treat the underlying cause. So if there's adenoids, you treat the adenoids. Remember, unilateral conductive hearing loss in an adult, always rule out a nasopharyngeal pathology, even in a child as well. But most often when you have an adult above the age of 60 years presenting to you with unilateral nasal obstruction and otitis media with effusion with conductive hearing loss, rule out nasopharyngeal carcinoma. Good evening, Dr. Meenakshi. The other important modalities of treatment of conductive hearing loss are hearing aids. You can use hearing aids. Otosclerosis, you can use hearing aids, definitely. And then you have bone anchored hearing implants, because the bone conduction of the cochlear reserve is good in conductive hearing loss. You can use bone conduction hearing aids. And then you have the newest modality of treatment, that is osseo-integrated implant steady state, which is also known as OSSEA. This can be one of the options later on in the future whenever an MCQ test is given to you. So when you talk about bone anchored hearing implants and osseo-integrated state or osseo-integrated implant steady state, what are the differences between the two? The main important difference is OSSEA is through the skin. There is a magnetic component. So if you have skin right there, when you talk about BAHA, it's got a abutment with a screw which is passing through the skin, and then you have the processor which has to be attached. So if this is the bone, the abutment along with the screw is fixed to the bone, and then the screw comes out which is attached to the processor which is outside. So it has to be screwed to the the screw which is lying outside. But when you talk about ossia, it is through the skin. You have skin, there is a magnetic component under the skin, and you have the processor which sticks through the skin to the magnet. It is similar to a cochlear implant which is being used, but this is a bone conduction hearing implant. Let's come to the next question. Straightforward. There are three options there which are in favor of obstructive sleep apnea. So it's a straightforward question. Remember to read the question properly in any multiple choice examination. So you have an obese man, daytime sleepiness, disturbed sleep. Diagnosis is obstructive sleep apnea for sure. Here the question is accept. A 43-year-old obese man presents to you with daytime sleepiness and disturbed sleep. All the following features are correct except, right? I have put that in capital, right? So when you talk about the options, you had three options with apnea. Obviously, it's going to fall down, right? So all these options are ruled out. So apnea is present in obstructive sleep apnea. Remember, in obstructive sleep apnea, there is an apnea. Following apnea, there will be hypercapnia. There is a stimulation of respiratory drive following hypercapnia. And when there's a stimulation of respiratory drive, which obviously leads to, the hypercapnia obviously leads to fall in saturation of oxygen. Stimulation of respiratory drive results in a sort of a waking up spell. So the patient will not have a good sleep at night. He will have early morning headaches, excessive daytime sleepiness, disturbed sleep, and the various questionnaires that have been put forth to sort of subjectively evaluate obstructive sleep apnea are: one is known as the stop bang questionnaire, the second one is known as the Epworth Sleepiness Score. But the diagnostic modality of choice in obstructive sleep apnea is polysomnography. If we were to find out what is the level of obstruction in sleep apnea, you can always do a sleep MRI or a drug-induced sleep endoscopy. So two investigations to find out the level of obstruction, one investigation that is polysomnogram to find out what is the degree of sleep apnea. Is it mild, moderate, or severe? So if you look at the polysomnogram, you measure something called as the apnea hypopnea index. If it is between 5 to 15, it is mild OSA. 15 to 30 is moderate OSA, and more than 30 is severe obstructive sleep apnea. If a patient has got snoring with an AHI of less than 5, think of it as a simple snoring. It is not related to obstructive sleep apnea. Now let's come to the fourth option. During sleep, what happens? The muscles relax, right? So pharyngeal muscle contraction itself is ruled out as an option. The pharyngeal muscles relax, the palatal muscles relax, the retropharyngeal soft tissue comes in front, the palate goes behind, the tongue falls behind, and because of this there is snoring in a patient with obstructive sleep apnea. They can have a single level obstruction or multi-level obstruction. Just to put a few slides on obstructive sleep apnea here, what are the factors contributing to obstructive sleep apnea? Obesity, male sex because of testosterone, postmenopausal female. Remember, in women, progesterone is found to be protective. Increasing age, there is narrow and collapsible airway, so they are more prone to develop obstructive sleep apnea. Skeletal abnormalities can produce obstructive sleep apnea. If you have a receding mandible, if you have a maxillary hypoplasia, you can develop obstructive sleep apnea. Short neck is one of the contributing factors. If there is obesity, obviously there will be a short neck. Increased neck circumference, increased abdominal circumference, all of them contribute to obstructive sleep apnea. You have adenotonsillitis during childhood, produces obstruction in the airway. Nasopharyngeal obstruction due to adenoids and oropharyngeal obstruction due to enlarged tonsils can lead to also abnormal craniofacial development, but it in itself can produce obstructive sleep apnea. What is protective? This is what you need to remember. You can have progesterone in females, geniohyoid and genioglossus activity. If these muscles are very active during sleep, they are protective against obstructive sleep apnea. Good evening, Dr. Vidya and Dr. Shimona. Then we have serotonin. Serotonin is responsible for your sleep-wake cycle. It regulates the sleep-wake cycle. It is responsible for a hormone called as melatonin. So this is protective against obstructive sleep apnea. And Caucasians as a race itself is found to be protective against obstructive sleep apnea. What is responsible for upper airway collapse? There is edema, that is secondary to snoring, muscle damage due to increased workload. There is increased muscle activity during obstructive sleep apnea, which can produce a responsibility towards upper airway collapse, and sleep deprivation impairs the upper airway dilating muscle activity, so they tend to collapse. So the sleep deprivation is one of the other factors that you need to keep in mind. Now let's go to the next question. If you have any questions, you are free to ping. I would be more than happy to answer. Which of the following structures passes between the superior and the middle constrictors? We don't have the options yet, but if you had any one of these 4 options, it is correct, right? When you talk about the muscles of the pharynx, you have the constrictors and the pharyngeus muscles of the pharynx. When you talk about the constrictors of the pharynx, you have the superior, middle, and the inferior constrictor. So when you talk about the gaps that are present between all of them, you have the skull base, right? Between the skull base and the superior constrictor muscle, there is a gap that is known as sinus of Morgagni, right? So what passes through the sinus of Morgagni? You have our very famous Prime Minister Atal Bihari Vajpayee. Remember Atal, right? So what do you have? You have the most important structure that comes to the nasopharynx, that is the auditory tube. You have the tensor veli palatini muscle. The accompanying muscle to that will be the levator veli palatini muscle. And you have the one artery, that is ascending palatine artery. So these are the structures that pass between the skull base and the superior constrictor muscle. Now let's come to the next important thing. You have the superior and the middle constrictor. What is the question that was being asked? These are the structures. You have stylopharyngeus, stylohyoid ligament, glossopharyngeal nerve, and lingual nerve. If you look at it, more or less it is the third arch there, right? Except for the lingual nerve, I were to say. So you have 3 important structures there, right? Stylopharyngeus, stylohyoid ligament, glossopharyngeal nerve, and along with that you have the lingual nerve. So remember, 2 nerves, 1 ligament, and 1 muscle. Now let's come to the middle and the inferior constrictor muscle. What are the structures that pass through the middle and the inferior constrictor muscles? You have the superior laryngeal vessels, and along with the superior laryngeal vessels, you have the internal laryngeal nerve, right? One vessel, one nerve. Superior laryngeal vessels along with internal laryngeal nerve. And then below the inferior constrictor, you have the next important component. If there's a superior, there has to be an inferior, right? So inferior laryngeal vessels, and along with that, the friend that goes to the larynx, you have the recurrent laryngeal nerve, right? So these are the structures that pass through the various levels of constrictor muscles and between the constrictors and the skull base. Good evening, Dr. Vineet. Right. Famous reel that we have done in Manipal MedAce. Which of the following is not a feature of allergic rhinitis, right? So this question we have depicted in the form of a reel. If we were to say we have depicted all the features here, except that we don't have, some of us don't have allergic shyness or Denny Morgan folds, but definitely allergic salute we have shown in the reel as well. So which of the following is not a feature? 2 have got allergic component. I'm not sure whether these were the right options, whether there was only shyness, whether there was only salute given, but definitely these 2 options are ruled out because allergic rhinitis has these 2 features. So what is allergic shyness? There is venous stasis in the eyelid, in the lower eyelid, which produces a blackish purplish discoloration, which we commonly call as dark circles. So the dark circles that are there are called as allergic shyness. What is allergic salute? People who have allergic rhinitis have a tendency to rub their nose, right? That is allergic salute, right? So allergic salute is very common in cases of allergic rhinitis, and this allergic salute, what it can do is it can produce a transverse crease over the dorsum of the nose. So there will be a transverse crease over the dorsum of the nose seen in allergic rhinitis, and this is known as an allergic crease. And there is one more important entity which is called as allergic grimace. You would have seen this in patients with allergic rhinitis, that is an allergic grimace, right? So that is one more feature of allergic rhinitis. Now let's come to the two options which some of you might have got confused with, but definitely if you have gone through allergic rhinitis as a chapter, there is no confusion at all. What is Denny-Morgan fold? There is spasm of the Muller's muscle due to hypoxia. So this is present in the lower eyelid. So there is spasm of the Muller's muscle because of hypoxia, which causes a sort of a fold in the lower eyelid, which is called as a Dennis-Morgan fold or a Denny-Morgan fold. And the fourth option what you had there was a Otto-Varagut fold, which is usually seen in depression. Okay, so Otto-Varagut fold is an upper eyelid fold which is seen in depression. Right? So three options ruled out. Right answer is Otto-Varagut fold, not a feature of allergic rhinitis. Let's come. Yes, absolutely correct, Dr. Vinay. Varagut fold is seen in depression. So the next question that was asked once again was a straightforward question. ENT was very easy in INICET, right? So which of the following is not associated with otitis media with effusion? Not, right? So the negative part again holds good. So go through all the four options before you choose a particular option. If you have a lengthy clinical question, try and find those impact words or keywords which will help you in getting the answer, right? So if you look at this question, bilateral, most often it is bilateral, right? Let's keep that on hold for the moment. Most often otitis media with effusion is bilateral. I had given you an example earlier where nasopharyngeal carcinoma can produce unilateral otitis media with effusion, but most often 80 to 90% or maybe more than 90% of the causes is to do with adenoid enlargement and otitis media with effusion, which is usually bilateral. Now let's look at resolves on its own. If the impending cause is removed, adenoid is removed, there is a tendency that otitis media with effusion can resolve in 4 to 6 weeks time. Remember, it can resolve on its own in 4 to 6 weeks time. Also mentioned in literature, also mentioned in your textbooks. AD curve on tympanometry, straight away you can take that as the answer. Why? AD curve is seen in ossicular discontinuity. Let me discuss a little more on this option. So when you talk about conductive hearing loss, definitely there is a conductive hearing loss in otitis media with effusion because there is fluid in the middle ear. Now let's look at what is AD curve. Let's go to tympanometry a little bit. What do you tend to see is you tend to check the compliance. Okay, let's look at this is a pressure 0, and if you look at minus 200 pressure plus 200 pressure here, this is pressure. This is compliance in ml or millimeter of water, whatever you want to measure it with along the y-axis. X-axis is always changes in pressure that you produce in the external auditory canal. A normal graph may look like this, right? This is an A-type curve in a tympanometry. So when we look at ossicular discontinuity, the compliance is very high at normal pressure. So this becomes an AD type of curve. D for discontinuity. Remember, AD curve is seen in ossicular discontinuity. The third important type of A type of curve, if I were to tell you, is a AS type of curve where there is a reduced compliance at near normal pressure. S for stapes. Stapes stands for otosclerosis. So in otosclerosis, you will get a AS type of curve, that is reduced compliance at normal pressures. Now let's look at what is there in the question. You have otitis media with effusion. It is a flat curve. Okay, you change the pressure in the external auditory canal. The tympanic membrane does not comply at all. There is fluid in the middle ear, and this produces a B type of curve. So this is the answer for otitis media with effusion. But remember, if there is a perforation in the tympanic membrane as well, it can also produce a B type of curve, right? So the pressure is not maintained. So otitis media with effusion, perforation in the tympanic membrane, B type of curve. So where will you get C type of curve? That is, you have at negative pressure it peaks. The C type of curve is usually seen in cases of a retracted drum, retracted tympanic membrane, or in cases of a negative pressure, right? So if you were to look at tympanometry, I've discussed a little bit on tympanometry right here, but if you were to look at the options in this case, it is the AD curve in this as the best option. Which of the following view is depicted in the radiograph? I'm not sure which of them was asked, but from the recalls that I have received, the answer was a occipitofrontal view, also known as a Caldwell view, right? This is more or less what is depicted here is the Caldwell view. So let me discuss a little bit about this view. So where is the Caldwell view used? Which is the sinus? If this question were to be twisted, an X-ray or a radiograph is given to you, which is the Caldwell view, and if they were to ask you which is the sinus that is well depicted in the radiograph, it would be the frontal sinus. excuse me. Right. So occipitofrontal view is also known as Caldwell's view. The best depicted sinus in occipitofrontal view is the frontal sinus. Occipitomental view is also known as, what is it also known as? It is also known as, can anybody answer that? Sorry. Waters view. Okay, so Waters view is the answer. So Waters view is occipitomental view. If it is occipitomental view is with mouth open, it becomes the Pierce view. Occipitomental view as such, the best depicted sinus is the maxillary sinus. Occipitomental view with mouth open, you are able to visualize the sphenoid sinus as well. Why is occipitofrontal view not good for the maxillary sinus? It is seen right here. You can see the petrous temporal bone lying in the floor of the frontal sinus, lying in the floor of the maxillary sinus. So it is not visualized well. If there is a minor pathology in the maxillary sinus, you will not be able to visualize as far as the occipitofrontal view is concerned. Hence, that is the answer. So when you talk about, I have just put this for completion. I was not able to get the other two options. Submental vertical view, it is also known as basal view or jug handle view, where you visualize the sphenoid sinus and frontal sinus from below. You can visualize the pterygoid ridges and the various foramina in the skull base. This view is usually not done nowadays, and this has been replaced more or less by a CT scan. Where is the Caldwell's view? This question here, once again, let's come back to occipitofrontal view. A point that I remembered just now. Where is the Caldwell's view useful? In cases of an osteoplastic flap operation. When you have a recurrent frontal sinus disease, the patient has already undergone a functional endoscopic sinus surgery. You would like to open the frontal sinus from outside. You need to map the frontal sinus. So you take out the occipitofrontal view, place it on the forehead, map out the frontal sinus or mark out the frontal sinus. You will be safely able to go into the frontal sinus by trephination or an osteoplastic flap surgery. So this is the only indication where an occipitofrontal view is done nowadays. More or less has been replaced by CT scan for functional endoscopic sinus surgery. So these were the questions in INICET. So if any of you have any doubts or any other questions were asked, I would like to put this on hold. I would wait for 5 minutes so that you are able to give me more questions or any other options that were present in the questions that have been shown in the following recall questions. Right, so more or less all the topics were covered as far as INICET is concerned. Let me run through the slides again. So what were the questions asked? First one was on thyroidectomy. We discussed the various triangles along with the classification, Cernia classification, Bayes triangle, why is it not tubercle of Zucker candle. Next one was on lower motor neuron type of facial paralysis. one more important point here I would like to put forth is one more pathology that is more commonly asked is the Melkerson-Rosenthal syndrome. When we talk about Melkerson-Rosenthal syndrome, it produces recurrent alternating facial paralysis along with orofacial edema and furrows on the tongue. It is known as Melkerson-Rosenthal syndrome. One more important question that can be asked in the future as well. Then there was a question on epistaxis, straightforward question where the answer was JNA. What you will not do in a case of bilateral sensorineural hearing loss. We've discussed the options of conductive as well as sensorineural hearing loss. You had obesity where a patient is more or less likely to have obstructive sleep apnea. What is the physiological component that is not present in obstructive sleep apnea? Then you had the structures, more of an anatomical questions, with structure passing between the superior and the middle constrictor muscles. Which of the following is not a feature of allergic rhinitis? And then otitis media with effusion. We discussed a few points on tympanometry. And then we had a radiograph which was depicting the Caldwell's view. So dear students, this was the INICET recall. And before ending this session, I would like you all to, or request you all to go through Manipal MedAce app. It's available on all the social media platforms. You are free to access this particular session and the various other sessions that are going to come on INICET recall, which will definitely be informative for you from the NEET point of view or any other entrance exam point of view. Do subscribe to us on YouTube, LinkedIn, Facebook, Instagram, and definitely if you find this useful, prescribe to the Manipal MedAce app, which is available on app stores, that is Google Play Store as well as the Apple Store. Thank you very much. Have a good evening.